All right.
All right.
Got
We're
it.
good now.
Okay, cool. Excellent. Good morning, everybody. Welcome to the Comparative Ocular Pathology Lab rounds. This morning, May 28th, 2025. I am Dr. Jamie Miller, one of the staff pathologists here, and I'm going to get us started with our first case this morning. So our first case is a 30-year-old male hornbill bird. Wasn't specified what kind of hornbill because there are a lot of them. But the history for this bird, they say that the right eye had some vitreal clouding and the left eye had a complete mature cataract. That their duration of the problem has been 3 years plus for this guy. They did note that he has concurrent chronic epistaxis events that has been controlled by long-term enalapril, basically at the time of his death. It didn't say why the bird died, but he's no longer with us. They were not sure of the cause of the epistaxis event, but I will tell you that they thought it was due to systemic hypertension. Oh, as I go ahead and spoil things for you, I'll move that keyboard. Okay, so we did get both globes from this hornbill. So we have our hemisections here. Our cornea is up at the top. We've got our lenses here. Left one's maybe a little bit more cloudy. The vitreous is also cloudy on both sides. We have the pectin oculi here that supplies is our vascular supply here to the retina and back of the globe. Maybe looking a little pale. And I think that was all that we could really tell grossly with these guys. So let's get started on the histology. Okay. So let's see. This is a really big globe. So it must have been a really big hornbill. So very briefly, subgross here, cornea at the top. Myself some room here. Here's our lens, iris leaflets here. Heading back, before I head backwards, there are sclera ossicles here. So there's these little bony things here in the sclera. That's normal, part of their anatomy. Here's the pectin oculi here, our retina, which we can see this ventral side looks a little bit different from the dorsal side here. And we can also see that our choroid here, kind of normal on this side, and it's kind of very edematous expanded on this side. So this one that I'm showing you is the right eye, right globe. And again, very large globe, so it'll be hard to get everything in the field, but we'll do our best. So again, front part of the eye, here's our cornea, here's our iris, lens stuff. Not too much going on in the anterior portion of this globe. Most of it, the significant findings were here in the back. So here is our pectin oculi. And if we take a look at the blood vessels here, we can see that they're really thick. And so their walls are the tunica media here of these blood vessels in the pectin are very thick, very hyperplastic here. There's a lot of like eosinophilic and even pale material surrounding, so like edema and like serum stuff around the blood vessels. And it was a pretty consistent finding in all of the blood vessels here in section. So I think this goes along with their suspicion for systemic hypertension. Here's a little bit of some hemosiderin-laden macrophages. Let's see. And every once in a while, very rarely here, see this wall here. We've got some like heterophils and maybe a little few lymphocytes, plasma cells in the wall as well. And so that was a pretty consistent finding. Again, here's, a blood vessel here. We can't really make out the lumen anymore. There's lots of edema and eosinophilic like serum and stuff surrounding these blood vessels. And then again, choroid over here looks a little bit edematous. It's very expanded, lots of clear space here compared to the other side. Here is the dorsal portion of our retina. Flip her in. Um, and the thing that we were looking here at the retina is that we had a suspicion that our outer nuclear layer here was a little bit decreased than, say, maybe normal or what we would expect to have here. There's a little bit of like eosinophilic material and maybe a little bit of blood underneath it, so possibly some retinal detachment. And then if we move ventrally here, we can see quite a difference here. We definitely seem to have a lot less of our inner and outer nuclear layers here. And then we even have this area where there's a full thickness atrophy of the entire retina. So very suspicious of probably vascular ischemic damage here from all the blood vessel changes. And to show you the left eye, as it also had similar changes, but even more so. So we head back up here. So in our iris here, we have one area. It's very round looking lesion with a lot of fibrin and a lot of blood. And so this is looking like a thrombosed vessel. Maybe got some lumens here, maybe starting to recannulize, but we've got some thrombus here, probably due to the hypertension and vasculopathy going on. And if we look at some of the other blood vessels here in the iris stroma, we can again see that they're very thickened, surrounded by, here we go, really thickened tunica media, smooth muscle cells, maybe a little bit of blood, maybe a few neutrophils, and again, kind of losing where the lumen is of these blood vessels.
Do you think that was an aneurysm?
Good question. Would that possibly an aneurysm? I don't know. Maybe. Could be. Would be a good reasons for bleeding. In addition, this lens also has cataractous change here. Focus in here. So we have some liquefaction of our cortical lens fibers. We got rounding up and more ganglion globule formation. Let you take in the look at these degenerate lens fibers here. Because in addition to our cataract here, we have some other changes. So we didn't get as great of a sample of the pectin here, but we can see that the blood vessel changes are similar on this left eye as well. We also have this lovely focus of osseous metaplasia here, kind of at the base. And if we follow the retina out, the retina is very atrophied, very jumbled. And then we start to pick up this eosinophilic material that looks a lot like lens fibers. And so this is lenticular metaplasia in the retina. So we get things that look like more ganglion globules. Occasionally we get ones that look like bladder cells where, here we go, you can still see a bit of the nucleus here. So this is usually a feature that we attribute to a previous traumatic event, which could also maybe account for some of the retinal detachment, which again might be overlain with some of the vasculopathy going on. Here's the other side, more of that lenticular metaplasia. So just really nice vascular changes in the bird that they thought was hypertensive. So vasculopathy in the pectin, there's some in the choroid and in the iris, some choroidal edema, left eye having that little thrombus, and maybe some also evidence of previous trauma with the retinal detachment and the lenticular metaplasia. A little bit of osseous metaplasia could be part of that too, and maybe even the cause for the cataract formation in this eye, because there really wasn't much of one in the right eye either. So, um, so just interesting to see the vasculopathy lesions in bird species. All right, moving on. All right. So this young lady here is a 5-month-old spayed female golden retriever dog. So she initially presented for some mild conjunctivitis, which they started treatment with tobramycin, and she got significantly worse within 48 hours. So at recheck, there was a negative stain uptake, but they started some serum treatment anyway. And another 48 hours, the dog just was described as not doing well. The eye was swollen. It was blue, so we can really pick that up here on this lovely clinical picture that was provided to us. We can see the conjunctival hyperemia there. Very severe blepharospasm and very painful. Um, let's see. Then probably a day or two later after this, she presented to the emergency service just from worsening signs. They did do a vitreous cytology, and they showed 3+ macrophages. And so they saw the ophtho department at the ER service, and they were concerned that maybe this could be blastomycosis. They did pull both urine and serum and sent that off for blastomyces testing. And I will say that it did come back negative. So otherwise, the puppy has been completely normal until last week, and these signs have been going on for about a week. Grossly, did not have a gross picture for this globe, but we did note that there was blood in the pretty much in all the chambers. So there was hyphema, the vitreous was solid hemorrhage. The retina was diffusely detached, and we also noted that it was not attached to the back of the globe. So a lot of times when the retina detaches, it still, maintains the connection around the optic nerve head. And so we can get like a little like tornado effect or like a seagull looking view for the retinal detachment, but we didn't see that in this case. It was kind of up against the back of the lens. And the other thing that was noted by the gross examiner was that we could not find the optic nerve head grossly. We did note that there was some like granular tissue on the back of the globe, like in the area where the optic nerve would be or should be. Sometimes the stuff back there can feel a little bit firmer and granular if they use cautery to remove the globe and get a little bit of a cautery artifact where it kind of stiffens the tissues up there. So let's take a look and see what's going on. Oops. In this one.
Does talking of visual deficits prior to this considered?
So the question was, did the dog have any visual deficits prior to the presentation? And not that we were told. Seemed normal. And again, the initial presentation complaint was some mild conjunctivitis that just started to get worse. Possibly owners didn't notice. The other eye was also noted to be normal in this dog. Okay, so here's our subgross. Again, cornea up at the top. We can see lots of our intraocular hemorrhage here. We have one iris leaflet here. And we have this little nubbin over here, which is our other view of our iris here. So it's being shortened and nubbified. Very technical term here. Our lens was it was fairly unremarkable. Again, lots of hemorrhage here. We can see our retina is detached and it's multifocally fragmented. We'll take a closer look here. We've got some nice rounded edges here to help signify true tear here, in vivo tear versus artifactual tear. Here is the area where the optic nerve should be. And again, we don't see any optic nerve here. We don't see any optic nerve head coming into plane of section here. And then we often have an additional radial section of the globe that we often take with our cases just to give us an extra view of our iridocorneal angle. So heading up towards the cornea here. All right. So actually, our corneal epithelium is a little bit hyperplastic. And the other thing that we can notice here, as we zoom in a little bit closer, we'll get here, this in, is we start to see, closer here, this deeply basophilic material here, right where the basement membrane is and kind of the anterior corneal stroma. Go a little bit closer. And so this is some mineralization that is occurring, so band keratopathy in this patient. Also in this field of view, we can see our corneal stroma here, this band of mineral here, and then we can see this extra little bit of like fibroplasia and material in between the stroma and the epithelium. And so this is a little bit of anterior stromal remodeling. So it implies that the epithelium was maybe ulcerated or detached, maybe a little subepithelial bulla. And it's kind of the eye is trying to remodel that area and bring the epithelium back in contact with the corneal stroma. I will note that, wow, sorry, that the mineralization in this eye is something that we see in the younger dogs. It's a little bit more chunky than in the adult dogs, where it gets a little bit more like fine and stipply. I don't know that we have a really good reason for that. It's just something that we note. So sometimes we morph it out as a chunky band keratopathy, just to keep track of that. All right. Let's see, we can see some blood vessels and neutrophils moving in here, part of the keratitis. Our intraocular hemorrhage. Here is that little nubbined iris leaflet here. And that is due to this really robust fibrovascular membrane that is on the surface of the iris. And it's coming down here, it's crossing our iridocorneal angle here, attaching to Descemet's membrane. And so it's causing some peripheral anterior synechia as well as some iris distortion. So you can see that a little bit on the other side. We can see lots of the hemorrhage that's draining out through the angle and through the cleft here. Lots of hemorrhage in the vitreous. And let's see. So if we come and take a look at this retina, so there's definitely atrophy here, and we get a little bit of jumbling of our inner and outer nuclear layers here. We can't really tell which is which. We can see that there's no retinal ganglion cells here either. But the other thing that is missing from this retina are blood vessels. So there are no blood vessels in this retina. So this retina is avascular. And that was a very consistent finding diffusely throughout the retinal fragments. And then again, retina is torn. So we've got these lovely little rounded edges to our torn pieces. This one's even better. And so this represents kind of an in vivo tear versus, say, a boxy tear like this. So this would probably is more of an artifactual separation of the retina here that just happened during processing. And so we like to see these kind of nice rounded margins to give us an indication that the tearing effect happened prior to fixation and such. And then again, here is where the optic nerve should be, and there is no indication that it is here at all. And so no optic nerve head, there's no break in the, maybe a little bit of break of the sclera where the blood vessels are starting to come through, but not there. And I will say we looked at several sections of this for this optic nerve and could not find it. So this is just one more representative sample here There's blood vessels, and so this is probably some of that tissue that we were feeling grossly in the area where the optic nerve should be, but it is not there. So uh, basically, we've got some lovely congenital abnormalities in this young pup. So the complete retinal detachment, possibly even non-attachment, it's hard to tell at this point if the retina was ever attached, or if the retina became detached after development. And then again, a presumed optic nerve aplasia. We could not find it grossly. We looked through several sections histologically, and we just couldn't find it at all. So in all likelihood, the detached retina with having no vascular supply was probably producing a lot of VEGF, trying to create fibrovascular membranes to get some of that blood flow going. And leaky membrane formation could have led to the intraocular hemorrhage, although in likelihood the eye was probably also blind, so we can't rule out trauma to like a blind eye contributing to all that intraocular hemorrhage. There Yeah, the fibrovascular membranes and the peripheral anterior synechia made it hard to look to really define if there are any other congenital abnormalities with the iridocorneal angle. See if there's anything with like anterior segment dysgenesis going on in this pup as well. But otherwise, there is really no indication that the other eye is at any increased risk for having congenital abnormalities. But they could obviously keep a good close eye on it. We did not see any inflammation of any kind, so where all of those macrophages came from their vitreocentesis or acreocentesis, is unclear. But with all the hemorrhage and stuff, if there's macrophages floating around, it could be secondary to that. So no inflammation, no infectious etiology, and no neoplasia in the scope.
Heritability.
Pardon?
Heritability.
Inheritability. Good question. I don't know. I think I've seen something recently like miniature poodles might have heritability for this, but I don't know that we see it all that often to have a comment on that.
Is it associated with any other congenital? No.
Is it associated with any other congenital abnormalities? I don't think so. Not that I know of. Awesome. Cool. Thanks. And I will make way for Dr. Bluemans.
Megan, I'll do 2 more cases. And we'll start with a 10-year-old spayed female pit bull terrier mix. History is short and sweet. Hyphema, flare, iris bombay, glaucoma. That's it. That's really all we need. In the gross view, we have all of those things. So it's hard to see exactly what we're looking at here, but way sort of deeper in on the globe, we have the anterior lens surface, and the iris is sort of fused focally on the anterior lens capsule. And then what we're looking at here is the iris is sort of ballooning towards us. So if you kind of could see the other side, it would also be another balloon. And if you could see it from the front, it kind of looks like a donut. But anyway, that's iris bombay. So iris bombay, we saw that as well. The anterior chamber for us was pretty narrow to collapsed. What we can see is hemorrhage in the posterior chamber at least. So yes, to a little bit of intraocular hemorrhage to go along with their hyphema. And then the main event that we can't ignore like an elephant in the room. We have this plume of exudate in the vitreal space, and the rest of the vitreous is quite cloudy. So interestingly, this exudate was very centered kind of on the ventral side of the globe. And then there's this little hair-like doodad that was just sort of sitting there on hemisection. Interesting. Maybe we can kind of see it on the other half as well. Maybe. There was a little bit in each of the halves. I tried to remove this from one half and section it separately, and it did not go well, but that's okay. We have some things to look at regardless. The other thing that I'll point out is in this half, the second half without the optic nerve, so here's optic nerve in this case, here's the second half without the optic nerve, the plume of exudate kind of seems to break through the choroid and maybe sort of extend towards the sclera here, although not quite through the sclera, which is interesting. So let's take a look. I think we'll start with this half and then we'll switch to the other one, maybe. Okay. So on subgrows, we can confirm that tent of anteriorly bowed iris from the iris bombay. We can confirm that little hemorrhage, and we can confirm that exudate in sort of the anterior vitreous or so. I think actually the other half is more what we want to look at, but start by at least looking through here. So when we're looking at this exudate in the intraocular space, one thing that we can see is that there are these multifocal spots of sort of more basophilic stained material, as well as a bunch of fibrin, this pink stuff. And if we look closer on the purple stuff, it's mostly just degenerate neutrophils, or maybe somewhat less degenerate neutrophils, necrotic debris, that sort of stuff. And as we look around, we just see tons of friends where that exudate was sort of even more darkly staining. And so these are bacteria. And in particular, we tend to have cocci and chains, but to some extent, this was kind of mixed morphology bacteria. But what about our little hair-like friend? Like I said, that one extra slide I tried to make was useless. However, we have this lovely slide here. And if we take a look in the exudate on this side, we have this lovely structure. So surrounded by that suppurative exudate, we have this sort of poorly staining structure, which has very rigid and thick walls that disclose these sort of rhomboid compartments, and it has a lot of bacteria colonizing it. And if we polarize it, I always forget that this polarizer works differently. It's very pretty. And then we can disco it. All right. So it's a little bit it is birefringent. All right. So this is a plant foreign body. So long story short, in this case, what we have is a migrating plant foreign body. I was very sad because I was expecting on this second half to catch that area where it looked like it was starting to communicate through the wall of the eye, but we did not. But I would bet that it came through the ventral part of the eye, given how the exudate is situated and given the gross findings. And when we have a penetration site suspected in the ventral part of the eye, the strong suspicion is that it may have come up from the oral cavity. If it's more dorsal, it may have come more from sort of the outside of the patient in. But that's the main things. We have a migratory plant foreign body that caused an endophthalmitis and carried a bunch of bacteria into the globe along with it. Good question. We have a question about the geographic location of the patient, and it is California. Shock of shocks. Many of the plant foreign bodies we get come from California. So good question. Thank you. Good assist. Yeah, all right. A cool plant foreign body case. If there aren't any questions, we'll do the next case. Horrible next. Yes, so it is very hairy in more than one level. Yes. So this is a 15-year-old neutered male domestic short-haired cat, and their description of the globe is pretty much our description grossly. No normal globe anatomy appreciable clinically. Extensive friable tissue covering the globe and the orbital opening. And indeed, this globe is basically consumed by a large tan mass. So we have, our hemicentered view can at least see a little bit of sclera here. So we have got sclera, I'm following with the mouse here. But other than that, and maybe a little bit of uvea, you can kind of make out some of the choroid in terms of it being a little bit brown embedded in this mass. But apart from that, there really isn't any obvious globe anatomy. It's hard to see where the cornea is. We don't really see a lens. We don't really see a retina. All the intraocular spaces are essentially occupied. And then because we can follow the sclera, we can see that this abnormal tissue extends into the episclera and orbital tissue of this animal. And then the surface is looking really roughened and ulcerated, and it's got little hairs in it and stuff like that. So really uncomfortable ocular surface as well. Another piece of history that I think is important for this case before we move to the histology, they know that this patient had a blunt trauma to this side of the head about 5 years ago. However, I may be baiting and switching you slightly. Slightly. Let's see about a subgross. The dust. So this is kind of where the ocular surface would be, although we still can't really make out a recognizable cornea. A lot of this mass is quite purple, which implies a lot of cells, but vast swaths of it are quite pink, which implies necrosis. We can pick up the sclera again on that one side like we saw in the gross with this pink collagen, but everything's pretty distorted and very hard to make out our actual anatomy of our globe. But we do have a little tag of tissue right next to where optic nerve was, and we don't really have a great section of optic nerve, but there's suspicious purpliness near where the nerve is as well. All right. So let's start by identifying the main thing that we're looking at here. I'm going to go way out here where it's much less necrotic, and then we're going to drop in where the cells are viable. So we're out here in kind of episclera, orbital tissue. Yeah. So it turns out we do have neoplasia, but maybe not the neoplasm you were thinking it might be, given the history that I just gave you. So instead, this is a population of round cells arranged in two sheets. The round cells have nuclei with vesiculate chromatin and typically a single distinct nucleolus. Those nuclei are typically 2 erythrocyte widths in diameter or greater. So these are pretty large round cells. And yeah, so we have a somewhat monotonous, although there's quite a good variability in nuclear diameter at a bare minimum, round cell population forming sheets. And what this is a lymphoma. If we move over here to sort of do some more of the stuff, so here's where ocular surface would be. This is anterior-most globe, at least. And what we see here is this really thick layer of stuff that is basically just bright pink, kind of paucicellular. Basically what this is just a giant mat of necrotic crusted material, basically just a giant serous-cellular crust on top of necrotic tissue. Here we go. We can see occasional hair shafts embedded, just like we saw at the gross exam. So the ocular surface is kind of no more. And we just have tumor immediately beneath that, wherever we can see viable tissue. Over here, we can see a nice pattern where it's surviving around blood vessels. So you can see that there's necrosis in these vast swaths, and then the purple is pretty much just around the blood vessels where the oxygen is and the nutrients are. And we can confirm that that's neoplastic cells surviving around the blood vessels with seas of necrosis adjacent to. You can even see that they still look like round cells in their ghostly dead form over here, which is kind of fun. But you can't really make any interpretations based off of necrosis. Another thing that we'll look at as we go a little bit further back, assuming I can find it again. There it is. Here in roughly the level of posterior chamber, where posterior chamber once was, we have fragments of basement membrane, and they're wrinkledy and they're multifocally discontinuous. Here's some ends. And this is just fragmented lens capsule, and that's all there is to lens. It's just fragments of lens capsule. I don't see any normal lens fibers there, just squished in the middle of all of this necrotic tumor. So we did have a lens capsule rupture at some point, which goes along with our history of trauma 5 years ago. And other than that, there's not much else to show. It's mostly the same tumor. You can see it out here in the orbital tissue again. And that area that was right next to the optic nerve, you can see it if it invading the orbit. And margins were incomplete, unfortunately. I think there was some suggestion of vascular invasion at some point, but I'm not going to keep digging for a really convincing vessel for ages and ages. So, this is a lymphoma, and in particular, with the history of trauma and potentially really chronic inflammation inside this globe, and with how destructive and sort of circumferentially invasive it is, we would think of this as a potential chronic uveitis-associated lymphoma. In Coplow, this was formerly referred to as post-traumatic sarcoma round cell variant. But it's not always seen with trauma. It could be any kind of chronic lymphoplasmacytic uveitis. And the thought in terms of etiopathogenesis in this case is that it's more transformation to lymphoma on top of a chronic inflammation at the site, much like you might expect with some cases of inflammatory bowel disease or things like that in cats. So just to keep in mind that in terms of post-traumatic sarcomas, the classic spindle cell variant is a lens epithelial origin. This is not. It is thought to be transformation from lymphoplasmacytic uveitis. And then we had the lens capsule rupture, and the lens fibers were either long since resorbed or potentially extruded at some point. It's hard to know if the cornea actually ruptured. It's essentially just defaced at this stage. Yeah, that is this case.
You have a question in the chat. Any evidence of systemic spread of lymphoma in this cat?
Any evidence of systemic spread of lymphoma in this cat? Not that they reported, but I believe we did suggest staging of this animal. So we would have to get follow-up to find out.
Right?
Okay.
No other questions?
And the floor to
No. Hey, Megan, do you want to watch the chat?
Oh, I would love to.
All right. I'm currently masked up with a slightly sore throat, so I'll try to enunciate as well as I can. My apologies if I sound a little bit muffled. Okay. I have two more cases to take us through to finish us off. This first one is the globe from a 13-year-old male castrated Siamese cat. And the somewhat lengthy history, I'll summarize it. So this is the right eye from this cat. It was enucleated due to a previously diagnosed anterior uveal mass, which they described as posterior to the iris in the ciliary body / interior choroid. They also diagnosed secondary uveitis and retinal detachment. During surgery, they did note that there was abnormal fibrotic and friable tissue adhered to the sclera, and they mentioned thickening of the ventromedial episclera. So this image is the gross hemisection from that globe. The globe is quite distorted. So we can see the posterior segment is kind of pinched in a little bit. And we do have this tan thickening of the episcleral connective tissue, the orbital tissue. Maybe we're kind of seeing that tan tissue creep into the sclera a little bit as well. Looking within the globe itself, it's a little bit hard to make out everything. We can obviously see our lens, but everything in the posterior segment is kind of distorted just due to this kind of collapse and being pinched in. But we can see our retina here. It does look like perhaps it is detached. We have this kind of serpiginous folding of it. And we can see our iris leaflets up top. In terms of an intraocular mass, we did not grossly see one. We did note again this thickening here, so potentially this could be causing kind of this infolding and creating what clinically would be seen as an intraocular mass effect. But we did poke through, we looked at both halves very extensively and didn't see an overt kind of primary intraocular tumor. Okay, so let's move to the histology. And this is gonna work. Okay, so cornea is up top. It looks pretty unremarkable. Looking within the eye itself, we can see that retina, it does look detached. Everything else within the globe itself is rather unremarkable. The main event is happening in the orbital/episcleral connective tissues. From this very low power view, it just looks much busier. There's a lot more purple and kind of blue, which usually indicates increased cellularity. And it's a little bit over on this side too. I'll mention this is the ventral aspect, which is where they describe that intraocular mass. And this is going to be our dorsal side. But regardless, there's kind of the circumferential increased cellularity and thickening. Okay. So I'm going to focus. There we go. So I'll just quickly kind of move over the actual ocular structures, and then we can show what's happening outside of the globe. So there is very mild vascularization of the stroma. Rest of the cornea itself is rather unremarkable. There's this kind of small little area where there's a discontinuity in the corneal epithelium, which could equate to an ulcer. It could also just be artifactual. Sometimes we'll rub off the epithelium when we're grossly dissecting the globe or even during surgery. Looking at the iris itself, there is a little bit of inflammation. They did mention the secondary uveitis, and we can corroborate that. So there's some lymphocytes and plasma cells in the iris and ciliary body. It's rather mild. There's a little bit of a cataract, so we can see this liquefaction of the cortical lens fibers. In some areas, they start to form more ganglion globules. Oh, gosh. There we go. Here, which is a hallmark of cataractus degeneration. We also have posterior migration of the lens epithelium, which is another hallmark of cataract. Moving back to show our retina. Ooh, struggling to focus today. There we go. It is truly detached. We have these areas where there are these spaces in the outer/inner nuclear layer, consistent with retinoschisis. And there are areas, if we go closer, where there we go, where we have atrophy of that outer nuclear layer, likely as a sequela to retinal detachment. In some places, it looks like there's almost a full thickness retinal atrophy. All right, so let's actually move to outside of the globe, the elephant in the room. So starting on the dorsal aspect, which is maybe a little less affected. We kind of just have this spindle cell population that's kind of coursing through the normal episcleral connective tissue, kind of dissecting the collagen bundles of the episcleral tissue. And as a rather fresh pathologist, an ocular pathologist, I got very excited thinking, could this be FRONS, which is feline restrictive orbital myofibroblastic sarcoma, a mouthful, which is a tumor. It is a neoplastic proliferation of bland spindle-shaped cells. And they kind of just cause a vague thickening of the orbital tissues. And usually it is, just these bland spindle cells dissecting the fascial planes. So I got very excited about that from this view, thinking, could it be that? However, as we move around, let's maybe go to this region here. Oop. Dropped down way too fast. Trying to be very dramatic. There we go. One day. There we go. We get to areas that are not quite as FRONS-like, one might say. So these cells are no longer very bland or spindle-shaped, really. They become a lot more plump, almost polygonal in regions, and they're very pleomorphic. Typically with FRONS, there's a very low mitotic rate. As I mentioned, they're quite bland, so there's really not much atypia. These cells get a little bit freaky, for lack of a better word. So there's this really coarse chromatin. Oftentimes they have these really irregular looking nucleoli. Some of them have 2 up to 3. And there is a somewhat robust mitotic rate. Here's a mitotic figure right here. And these cells are just really quite disorganized. And there's a very bizarre mitotic figure that is not doing anything productive. And these guys are kind of just all throughout the orbital tissues. I can zoom in a little bit. There are these little aggregates of lymphocytes. as we move out this way. So here's a little bit of our bulbar conjunctiva. They're also within the substantia propria. So they're exhibiting very, very invasive behavior. So looking at these cells, this really is not super consistent with FROMS. I got very excited about that, but it became much lower on a differential list. Given the morphology of these cells, we started to think about, could this be an epithelial population, so a carcinoma? One could also wonder about a melanoma, since it can do whatever it wants, and oftentimes we'll see these really large owl eye nucleoli. But again, that might be a little bit lower on the list, given that it's kind of just doing this infiltrative behavior and not really making a discrete mass effect. In cats, there are carcinomas that can kind of show this behavior where they're just infiltrative without forming a discrete tumor. Specifically, we think about orbital invasive squamous cell carcinomas. So that became kind of higher up on our list. I do have some IHC to show. Before that, I will quickly, again, mention the intraocular tumor described clinically. We also histologically did not see any obvious intraocular tumor. We did wonder there are areas where this infolding of the sclera, which possibly, again, could have conveyed kind of an intraocular mass effect seen through the cornea. So I'm not one for suspense. I'll just go to the most important IHC marker. So this is the cytokeratin, which is going to be an epithelial marker. So specifically, it's going to stain the cytoplasm of cells with epithelial phenotype. So in this case, here are those really pleomorphic cells in the orbital tissue, and they are showing quite strong cytoplasmic staining. So consistent with an epithelial neoplasm, i.e. a carcinoma. And in this case, this carcinoma isn't really showing us who it is. So it doesn't really look like a squamous cell carcinoma. It's not making any glandular formations. So it's a little unclear who he is. We can really just say this could be originating from like the surface epithelium. It could be originating from glandular components, but it's a little bit hard to say the precise cell of origin in this case. And then for fun, I also have a smooth muscle actin. That is something we see. The eye has the weirdest IHC profile. That is all I can tell you. What's that? Oh, the question was, why is the optic nerve staining with cytokeratin? And that is a normal finding we see with cytokeratin in the eye. I don't have a great reason for that. But IHC in the eye generates much confusion, at least for me. I am baffled by the things that label with various IHC markers. Yes.
Also those cases.
So this is our smooth muscle actin. So we have some nice internal controls. So we have the normal muscle. We have areas with blood vessels, and that's just the normal smooth muscle labeling. And as we go out here, we find areas with of our atypical cells, which are not showing any immunolabeling, which is what we would expect with a carcinoma. And then all that stroma, all of those spindle cells that I was pointing to earlier, are showing pretty robust labeling. So likely the stroma is a desmoplastic response or myofibroblastic response, which we often associate with carcinomas. So it kind of helps wrap all that up into a neat picture. All right. So our diagnoses, so just called this a poorly differentiated carcinoma that was showing markedly infiltrative behavior. Unfortunately, it was dirty margins. So in this case, we cautioned them and had them ask them to monitor the surgical site at a bare minimum.
I'm being an excellent monitoring of the chat
Yes.
in that Jamie tipped me off to that there being a chat despite the screen in front of me. Anyway, what do you think about a malignant myoepithelioma?
Malignant myoepithelioma. Well, I mean, in this case, the presumed neoplastic cells weren't SMA positive and were cytokeratin positive. So I think it'd be unlikely in this case because of that.
Okay. And Kelsey, I'm sorry if
Yeah.
you said this. Did we have third eyelid in the sample? Did we receive?
You do. Dun-dun. It's submitted separately.
Oh.
Here is our third eyelid, and it has a similar population too.
But not the gland itself, is it?
No, the gland itself looks pretty good. There's some inflammation in here, but we can still see somewhat normal glandular structures. So it doesn't seem to be effaced by this population.
Interesting.
But the conjunctiva of the third eyelid gland has a similar epithelial population.
Myelopathy are benign, right? Salivary origin is what I just found.
Yeah, they didn't specify malignant myoepithelioma, but
So, yeah. In this case, yeah, hard to give a more precise diagnosis besides carcinoma, which hopefully that was somewhat helpful. Yeah, either way, it's definitely not good news, whatever it's doing. Okay, and then I have my last one, if there's no further questions in the chat.
not that I can see.
Okay, perfect. All right, this last one's kind of short and simple. So this is,
Wait,
oh my gosh, okay.
tumor cells, cytokeratin positive and SMA positive.
The tumor cells were cytokeratin positive, SMA negative.
Yeah, the surrounding spindle cells,
Yes.
so the spindle cells surrounding the neoplastic cells were SMA positive.
Yes, as was like the stroma, which we interpreted to be just a desmoplastic response associated with the carcinoma.
Okay. All right.
Good
I've done
question.
my duty. All right. On it.
Okay. So last one is the globe from a 2-year-old male castrated domestic short hair. Lots of cats today. This cat was diagnosed with glaucoma. IOP was 85 to 93. They also mentioned a superficial corneal ulcer, and said there was prominent corneal edema that precluded visualization of the posterior segment, as well as the ability to assess for aqueous flare. So this is the hemisection from that globe. Indeed, the cornea is pretty cloudy, which could equate to edema, and there was this kind of just irregularity of the corneal surface, so potentially there is an ulcer here. It's just hard for us to see grossly. Other things, we did note that the globe was slightly ophthalmic subjectively. And on this hemisection, we can also note that there's increased depth in the anterior chamber. So here is the iridocorneal angle, and potentially this is where it should be, kind of closer to the cornea. So we have pretty increased depth of the anterior chamber, some recession of that iridocorneal angle. Other things, our lens did look like it had a cataract. It was somewhat cloudy. There's this kind of misshapen appearance to it. And it's a little bit hard to see in this gross image, but we did describe white opaque material extending out of the posterior lens into the vitreous, which potentially is a little bit hard to see, but I'm kind of tracing that material here. We also have the retina that's kind of confounding that finding too. It's overlapping with it, so maybe it's a little hard to make out. Our retina is detached, and we said that it was kind of hovering over the optic nerve head. We can kind of see this detachment between the retina and optic nerve head. And then also the retina is torn. There's this area here where we'd expect it to be attached, like yay here, and it's torn and kind of billowing into the vitreous. Okay. So, should grab the right slide. Okay. There we go. All right, so the subgross view, cornea is up top. There's a little scratch in this. I probably accidentally scratched the cover slip, so ignore that artifact. And we can see that there is indeed kind of a recession of our iridocorneal angle. Here's one of our iris leaflets, and we would expect the base of the iris to be maybe here-ish. And so it's kind of moved posteriorly. And that's also similar on this side. There's just that increased distance. Our lens is kind of flattened in the anterior posterior plane. There is definitely a cataract here, and there's kind of this extrusion of lens material out into the vitreous. So that's that white material we're seeing grossly. And our retina is indeed detached. There's this area where it's torn peripherally, and it also has kind of lost its attachment with the optic nerve head, which potentially could be artifactual, or it could signify a true avulsion of the retina from the optic nerve head. All right. Focus. Okay. All right. So our cornea. We can confirm that there was an ulcer. There's some areas where you kind of have these flaps of epithelium that have been artifactually removed, but there is indeed true loss of epithelium. We do have some stromal edema, so just areas where the stroma is a little bit more pale compared to, say, over here, where it's a little bit more eosinophilic. And there's a little bit of vascularization coming in too, which is kind of just non-specific and just means the cornea is angry about something. And as we look at the periphery, we have Descemet's membrane right here. And there are these large breaks in Descemet's membrane, mostly at the periphery. And moving here, here's that recession of the iridocorneal angle. And if we look at these iris leaflets, we can see the ciliary body plica are kind of coming off the back of the iris, somewhat at the base, which isn't normal in a cat. We do see this in rabbits. So if this was a rabbit, this might be a normal finding. But this kind of finding where we have the plica almost associated with the iris is atypical, and it's somewhat suggestive of cyclodialysis. So potentially kind of we had detachment of the base of the iris from the sclera, and it caused this kind of distortion and abnormal look of the iris and ciliary body. And that would also explain the iridocorneal recession that we see here. We sometimes wonder if iridocorneal recession in cats could be secondary to remodeling after cyclodialysis. And I can show this on the other side too. Again, kind of these ciliary body plica coming off of the posterior iris, which is atypical. And oftentimes when we have iridocorneal angle recession and cyclodialysis, we will see kind of this collapse of the ciliary cleft. We can't really make out trabecular meshwork. We do associate these with glaucoma, though it's sometimes hard to say which came first, glaucoma or the iridocorneal angle recession. All right, looking at our lens, indeed, there is a cataract. So we have some mineralization, we have liquefaction of the lens fibers, and then there's discontinuity of the posterior lens capsule here. And then all of the liquefied lens fibers kind of spooged out the back of the lens into the vitreous. Definitely lack of a better word. And then looking at our retina, as I mentioned, it's detached, it's torn. We have this kind of smooth rounding to this torn edge of the retina, which, as Jamie mentioned, it signifies a true retinal tear, as opposed to kind of the boxier edge that we see if it's an artifactual discontinuity. And looking at the outer aspect of the retina, this is where our photoreceptor layers should be, and we can't really make out the distinct inner and outer photoreceptor segments because this almost like fuzzy look about it, which we will see, especially in cats with blunt trauma. So the trauma that's conveyed, or the forces conveyed by blunt trauma, causes this kind of like shearing injury to the photoreceptor layer. So we'll see this almost like dissolution of the photoreceptors. And there are some areas where we have more of just a almost full thickness atrophy. So we can't really make out the photoreceptor layers or really any layers for that matter. It's just kind of a gliotic atrophied retina. And there are some areas of mineralization too within this retina. And then moving back, rest of the posterior segment isn't super remarkable. There is this atrophy of the optic nerve head. So we can say that there is glaucoma in this case. Sometimes with retinal detachment, we can't always diagnose glaucoma just because we'll still have preservation of the ganglion cell layer in a detached retina, and then it also causes distortion of the optic nerve head. So it makes it hard for us to actually see if there is atrophy and cupping of the optic nerve head. But in this case, we can say that there is truly chronic glaucoma. So I will switch over to the diagnoses in the PowerPoint. There we go. So kind of our major findings are all highly suggestive of blunt trauma to this globe. So the peripheral breaks in Descemet's membrane, iridocorneal angle recession, which is suggestive of previous cyclodialysis, lens capsule rupture, and then the retinal detachment and outer atrophy with the tear and probably optic nerve head avulsion. And so due to the cyclodialysis and iridocorneal angle recession, that likely was the cause of glaucoma. So secondary glaucoma due to impeded aqueous outflow. Also, this cat is a younger cat, which also helps support this being just a traumatic etiology. And that is it for this one. Are there any questions?
What is cyclodialysis?
So cyclodialysis, the question is, what is cyclodialysis? So your iris is going to be attached at the base to the adjacent sclera. So with cyclodialysis, you kind of get this tearing away of the iris from the adjacent sclera.
Dialysis means to separate.
Thank you.
Yeah, like renal
Yeah.
dialysis, yeah.
Sweet. All right. All right, there's no further questions, then that is it for rounds today. Thank you all for coming, and we'll see you in 2 weeks.
Cool.
Sharing, reduce.